Alright, future nurses, listen up. Let's begin. And today we are tackling a topic you will see a million times, both on the floor and on your big, scary NCLEX exam, cystitis. What is it? It's a bladder infection, a urinary tract infection, a UTI. It's that annoying, burning, gotta go right now feeling that sends patients flocking to your clinic. It's so common, it's practically the bread and butter of outpatient care. And because it's so common, the NCLEX loves to ask about it. They want to know if you can spot it, test for it, treat it without turning a simple bladder issue into a full-blown kidney catastrophe. Don't you worry, because I'm here to make this ridiculously easy for you. So, how are we going to do this? Are we going to read a 1,000-page textbook? No, we're going to use our brains, people. And to help our brains, I've cooked up some seriously simple, unforgettable mnemonics. They will help you slice through those tricky NCLEX questions like a hot scalpel through, well, you get the idea. It's your fast pass to understanding the core concepts of cystitis so you can walk into that testing center with the confidence of a surgeon who's never lost a game of operation. How do you know if your patient has cystitis? Are you a mind reader, a psychic? No, you're a nurse. You use your assessment skills. The patient's symptoms are your clues. And to make sure you don't miss a single one, we have the perfect mnemonic, FUD pain. It sounds like something an old cartoon character would yell, right? Oh, the FUD pain. Each letter stands for a classic sign or symptom of a bladder infection. Let's break it down letter by letter so you can become a symptom spotting ninja. F is for frequency. Your patient will tell you they feel like they have to pee all the time. They just went 10 minutes ago and now they have to go again. It's a constant nagging feeling. U is for urgency. This isn't just feeling like you have to go, it's the sudden, overwhelming, drop everything and run to the bathroom right now sensation. It's intense and hard to control. D is for dysuria. This is the big one, the telltale sign. It means pain or burning during urination. Patients might describe it as feeling like they're peeing razor blades, or like hot sauce. Ouch. The final D is for discomfort in the lower belly or suprapubic tenderness. That area right above the pubic bone feels sore, crampy, or full of pressure. Now for the second half, PAIN. P is for puria. This is a fancy word you'll see on lab reports. It means there are white blood cells, our little infection-fighting soldiers in the urine. To the naked eye, this can make the urine look cloudy or murky. A is for abnormal urine. The urine itself just looks and smells off. It might be cloudy or have a strong, foul, or even ammonia-like odor that's different from the patient's normal. Sometimes you might even see hematuria, which is a bit of blood in the urine, making it look pink or reddish. I is for increased temperature. Now, a high fever isn't typical for a simple, uncomplicated cystitis. You might see a low-grade fever, but if the temperature is spiking high with chills, you need to start thinking bigger, like the infection has traveled up to the kidneys. And lastly, N is for nocturia. This means waking up from sleep during the night because you have to pee. It's the nighttime version of frequency, and it's just as annoying. So there you have it, FUD pain. If your patient in an NCLEX question is checking off several of these boxes, your brain should be screaming, cystitis. Section 4. The detective work tests, labs, and the D-cup method. You've spotted the signs using your FUD pain superpowers. You suspect cystitis. What's next? You need proof. Play detective and gather evidence. Diagnostic tests are your toolkit. For the NCLEX, know which test and when. Remember D-cup, your step-by-step guide. D. Dipstick. Quick field test. Dip the strip into urine. The strip changes colors to show results. Look for leukocyte esterase. Look for nitrites. Leukocyte esterase, an enzyme from white blood cells. Nitrites, a sign of bacteria, often E. coli. If the dipstick is positive for one or both, you have strong evidence for a UTI. In a healthy young woman, this might be enough to start treatment. C. Culture. The urine culture is the gold standard. It's like sending the evidence to the crime lab. Take a clean catch urine sample and send it to be grown on agar. It takes a day or two. The culture tells the exact organism and antibiotic sensitivity. When do you need a culture? You don't always need one for a simple first-time UTI, but culture if the case is complicated. A man, pregnant woman, someone with a catheter, recurrent infections, or if they are not improving with the first antibiotic. Urinalysis. Think of this as a more detailed dipstick. The sample is sent to the lab to be examined under a microscope. It gives a precise count of white blood cells, red blood cells, and bacteria. Urinalysis can confirm the dipstick and show infection severity. It's often done alongside the culture, helpful to solidify diagnosis while waiting for culture, crucial for sicker patients. P. Picture. This means imaging, like an ultrasound or a CT scan. You do not need imaging for a simple bladder infection. Imaging is for complicated cases only. Get imaging if you suspect a blockage, like a kidney stone, or an abscess, or if you worry the infection has spread to the kidneys, pyelonephritis. So remember, picture is last and only if needed. For the NCLEX, stick to the basics first. Dipstick, then culture and urinalysis if needed. Don't jump to a CT scan for a simple UTI. Section 5. Calling in the cavalry treatment steps with ABCs. Okay, detective, you've confirmed it's cystitis. The enemy is identified. Now launch the counterattack. You need a treatment plan and to know your role as the nurse. Enter the final mnemonic, ABCs. It's the simplest one and it's your battle plan. Let's go through the ABCs and ace those treatment questions. A is for antibiotics. Antibiotics are the #1 weapon, the cavalry. For uncomplicated infections, short oral course, usually 3 to 5 days. Common choices: nitrofurantoin, trimethoprim sulfamethoxazole, fosfomycin. Nurse role: educate the patient. Tell them to finish the entire antibiotic course even if they feel better. Stopping early can cause antibiotic resistance. B is for bed rest and fluids. Not strict bed rest, encourage rest. Drink, drink, drink. Water is best. Goal: flush bacteria out of the bladder. Think of it like power washing the bladder. More fluids, more peeing, more bacteria evicted. Avoid bladder irritants, caffeine, alcohol, spicy foods, acidic fruit juices. Water is the winner. C is for check results and comfort. Check results refers to the urine culture if you sent one. Results in 24 to 48 hours. A provider must confirm the antibiotic choice. If not appropriate, adjust therapy. Comfort: symptom relief, heating pad for cramping. For burning pain, doctor may prescribe phenazopyridine. Warn: it turns urine bright orange or red. S is for symptom monitoring and seeking help. Teach the patient what to watch for. Expect improvement within a day or two. If symptoms worsen or new ones appear, red flag: high fever, chills, nausea, vomiting, severe flank pain, could be kidney involvement, pyelonephritis. Call the provider or go to the ER immediately. Good teaching prevents a simple UTI from becoming life-threatening. Section 6. Case files. 2 patients, 2 problems. Theory is great, but let's see how this works in the real world, or at least the world of NCLEX questions. I've got 2 quick cases for you, 2 different patients, 2 different scenarios. This is where you put your mnemonics to the test. Read the case, think and answer. No pressure, but your imaginary patient's imaginary life is in your hands. Let's see what you've got. Don't be nervous. You know this stuff. FUD pain. D cup. ABCs. Case file 1. Maria, the young professional. 24-year-old at urgent care. Burning when she pees. Dysuria. Constantly running to the bathroom. Frequency and urgency. She denies fever, chills or back pain. Vital stable, not pregnant, no major history, urine a little cloudy. FUD pain lights up like a Christmas tree. Question: most appropriate initial plan? Answer: do a urine dipstick. Fastest way: if dipstick positive for leukocyte esterase or nitrites, provider likely prescribes a short oral antibiotic course then and there. You don't need to wait for a urine culture in a young healthy woman with a simple UTI. Nursing actions: collect urine sample, perform dipstick test, teach about taking all antibiotics, encourage fluid intake, explain symptom relief. Simple, fast, effective. You crushed it. Case file 2. Mr. Lee, elderly gentleman, 78-year-old in long-term care, has an indwelling urinary catheter, new confusion and agitation, not his baseline. Fever 101.5 degree, 38.6 degree. Urine in catheter bag dark and cloudy, abdomen guarding and discomfort. More red flags than Maria's. This is complicated. Catheter-associated UTI cauti in an older adult. Question. Nurse's priority action. Priority is different. Notify the provider with your assessment findings. Get orders to act fast. Likely order. Obtain urine culture and sensitivity before antibiotics. Obtain sample from the catheter port, not the bag. Provider will likely start broad-spectrum IV antibiotics immediately after culture is obtained. Monitor closely for signs of sepsis. This is a whole different ballgame. Section 7. The final pep talk. Your NCLEX quick review. Alright, you made it to the end, see? That wasn't so bad. Cystitis isn't some terrifying medical mystery, it's a pattern, and now you know how to recognize it. Before I send you off to conquer the world, or at least the NCLEX, let's do one last super fast lightning round review. This is the stuff you need to tattoo onto your brain. This is your cheat sheet, your survival guide. When you see that question on screen, I want you to be so prepared you practically laugh. Okay? Maybe don't laugh out loud in the testing center, they might kick you out. First, let's drill those mnemonics one more time. FUD, pain, frequency, urgency, dysuria, discomfort, pyuria, abnormal urine, increased temperature, sometimes nocturia. These are your alarm bells. How do you investigate? With a D cup, dipstick first for a quick screen. Culture for complicated cases or to confirm. Urinalysis for a closer look. Picture, imaging only if you suspect a bigger problem. How do you treat it? It's as easy as your ABCs. Antibiotics are your main tool. Bed rest, take it easy and lots of fluids. Check results and provide comfort. And monitor symptoms, teaching the patient when to seek help. Remember the difference between your two cases. A young, healthy woman with classic symptoms and no fever, that's uncomplicated cystitis. Dipstick short course oral antibiotic patient education. But a man, a pregnant woman, an older adult, someone with a catheter, or anyone with a high fever and flank pain, that's complicated. That requires more investigation, like a urine culture, and often more aggressive treatment. Knowing the difference is key to answering priority questions correctly. Don't treat a complicated UTI like a simple one. Here is one final tip from me to you. Read the question carefully. The NCLEX loves to give you a bunch of information and ask you what to do first or what the priority is. Don't just jump on the first answer that seems right. Think about your patient. Are they stable? Are there any red flags? Use your mnemonics and your clinical judgment to guide you. You have the knowledge now. You know the patterns. You know what to look for and what to do. You are ready for this. Now go out there, be the brilliant nurse I know you are, and pass that exam. Thanks for watching.